Thank you.
Hello and welcome to the Federal. India reported the first COVID-19 case on January 27, 2020. Later, the country saw two major outbreaks in the form of two waves. The first one peaked in September 2020 with daily cases crossing 97,000. By March end 2021, the second wave had begun to gather momentum and India was recording 1 lakh fresh cases every day. At its peak in May 2021, the nation was recording over 4 lakh cases a day. By June end, it subsided, marking the end of the second wave. Since then, the rolling average, 7-day rolling average of COVID-19 cases have been falling every week. On September 24, it was below 30,000. The reproduction number, RO, which basically indicates how many persons a COVID patient can infect, dropped from its height of 6 to 8 during the second wave to below 1 now. What does that indicate? Have we hit a state of endemicity, which means the virus has begun to circulate at a steady rate? It would be around like a seasonal flu or a viral disease. People may still fall sick and some may even die, but the disease won't overwhelm the medical infrastructure the way it did during the horrid summer of 2021. The marvel of modern science has delivered us a quick vaccine, and today we know much more about the virus. But do we know enough? The rapid unlocking and awareness of the society as a whole has led to poor COVID-appropriate behavior. Concepts of face masking and social distancing are rapidly declining. Is it a recipe for a third wave? What about children? We are a young nation with a median age around 27, 28. Those below 18 years, and especially the school-going children, are at present without a vaccine. How vulnerable are they? To discuss, is India prepared for COVID third wave? We're joined by an eminent panel of experts. Welcome all of you. I have with me Dr. Chandrakant Laharia, a medical doctor, epidemiologist, vaccinologist, public health policy expert, and he's also a writer. Dr. Gautam Menon, Professor, Department of Physics and Biology, Ashoka University. Dr. T. Sundararaman, former Executive Director, National Health Systems Resource Center. Malini Aisola, co-convener, All India Drug Action Network. She writes regularly on public health issues. I also have my friend and colleague, V. Sridhar, senior journalist, till recently associate editor of the Frontline magazine. Welcome all. I would begin with Dr. Laharia. I have two questions. First, will there be a third wave? And if so, how prepared are we?
Thank you very much, Mr. Srinivasan. Whether there will be a third wave or not, it's really difficult to say about that. But epidemiology is one of the science which provides us some principle on which, based upon limited information available, we can make inferences. When we are talking in mid-October, there is some new update. We know through the nationwide sero survey, a series of sero surveys which have been done, including fourth nationwide sero survey, which found that 67.6% of Indian population had antibody, majority of them due to natural infection. And second set of information which we have is vaccination rate. So around 70% of India's population has received India's adult population has received at least one shot and protected. If we put all of these two set of information with other evolving scientific understanding, we can say that it is very unlikely that country is, or the setup like India is going to have a fresh national wave. So I want to quote unquote the national wave, because high seroprevalence, high coverage with antibodies, and science tells us that in a setting where there is a natural infection which is followed by at least one shot, it's very unlikely that susceptible population is very high. So, and some of the states have had a high seroprevalence such as Madhya Pradesh, Uttar Pradesh, Bihar, way back in end of June, for which sero survey indicate. And since then, vaccination coverage has gone up. So epidemiological principles tells us that in India, the probability of third national wave is very low. But that does not mean that there cannot be subnational waves. So there could be subnational waves, state-specific or district-specific rise in the cases. So that's a scenario which we are. But I'm fairly confident in arguing that a third national wave is unlikely, but state-specific waves are possible. What we also need to remember that we know that there could be a new variant which can emerge. But we also know through science that now only a new variant which is more transmissible will not be enough to fuel a next wave. A new variant need to have a immune escape ability, which essentially means it should be able to overpower the immune response of individual, natural response or vaccine induced. So highly transmissible variants such as Delta is unlikely to cause a big wave. It can cause a rise in the wave cases, but not so immune escape variant is required, and those are really possibility. And we really do not know. Virus has always surprised us. So that's a scenario. Second part of the question, whether India is prepared. What we need to do, we need to look back how India has responded to the first and second and ongoing wave. What we know that in the first wave, while the response was more of a nationally coordinated and much of the response was dependent upon lockdown. But if we look back, 20 months from March 2020, when it was declared pandemic, and if we start examining that how and what was the scenario of India's healthcare system before the start of pandemic and what is the scenario now, I would argue that hardly anything has changed except for the focus intervention for testing services. I would also argue that India has been saved by the medical care services in the private sector. The government health system and services even for COVID-19 has not sufficiently increased. So even the India's response, whether we are prepared, I would say that government health system is not any better prepared than it was prepared somewhere in March. There are minor tweaking in the testing or vaccination drive is happening, but the hospital beds and if other services are almost very similar. Of course, some of the attention has been given on paper to say that intensive care units have ICU beds have increased, oxygen beds have increased. But I would say that they might not be useful when actual challenge might arise because the human resources have not been increased commensurately. So putting all of those things together, there has been some attention, but whether those will be useful when the third wave or subsequent rise happens, that's very questionable. Mm-hmm. All of this putting to a final part is that whether we are prepared or not, I think if there is a rise in the cases as an entire health system, public and private together, we might be able to tackle the challenge. So that's a given. But whether government system is prepared, that's questionable, but it's variable. It will be variable in the states. States like Kerala, Maharashtra, or Delhi might do far better and they can tackle any challenge. But other states might not do that because through the government system, but the private sector system can help in that. And that's where we are. Thank you very much.
Okay, thank you. Dr. Gautam, I would like to go to you. Would you like to speak on this or should I ask the question right now?
I can go on and I think Dr. Lahari Chandrakant has really summarized it very well. That's pretty much exactly my opinion too.
So I want to take a point from there, if you permit me, otherwise you can say. See, I thought an interesting point he made is that now the spread will be more state specific, or it will be pockets of, look at that way. That's one point he said. And the second he says, the new variant, if at all there is something which emerges, which is immune escape. Now, beta variant actually had a more immune escape possibility, whereas the Delta is spreading very fast. But then beta didn't survive much. It is Delta which actually overwhelmed everything. Now, do we have enough studies to show which way things are progressing, if you include this in your presentation?
I think what we've seen from all the data so far is that Delta has just taken over wherever it could take over completely. It's just if you have a virus that is transmissible with reproductive ratio of somewhere between 5 and 6, pretty much it drives anything else out. Anything that has a lower reproductive ratio. The original variant, the original virus that came from Wuhan had somewhere around 2.3, 2.5. So I think the success of Delta is, I mean, in a sense, it is good. because it's hard to imagine something that might be much, much better at propagating than Delta. It just fits completely in the right spot. If you had something that was very immune escape on top of that, it's possible, but it would still have to match the same level of transmissibility the Delta had, which right now it looks as though from the sequence that you're really redoing changes and mutations that have been seen earlier. So we're not seeing anything new and very, very shocking or surprising yet. Although this is a big question mark. I mean, these are things that one cannot predict. One cannot predict what new unusual mutation might rise that might create a much more transmissible variant later. But the most sensible thing now would be to not think about it at all, because it's something that we cannot predict at all. We cannot prepare for. All we can do is to do sensible things regarding strengthening our own health system wherever we can as an overall bulwark, as an overall protection against anything that might happen in the future, but not specifically say that we anticipate that a particular more transmissible, more immune escape variant might arise in the future. Regarding the other point of what Dr. Laharia said regarding the country, I mean, I think it's true that a lot of North India is already seeing levels of seroprevalence after the ICMR 4 sero survey, which was in excess of 70 to 80% if you look at MP, if you look at UP, Bihar, etc. So it's only really Kerala, a sort of small section of states in the northeast, Maharashtra to some extent, that at least at the time of that sero survey were in the 40 to 50, 55 region. It's now they had cases that were carrying on long after UP, etc., had come down. So now those numbers would also have been bulked up probably to the level of 55, 60%. They've also had strong vaccination programs. So I think the combination of prior infection plus vaccination will really have pushed much of India up, right to somewhere around 70% plus in terms of seroprevalence if you looked at it now. And that, I think, is going to be the most important protective factor against a third wave. This is pretty much exactly what Chandrakant said. It's just if you look at the numbers, when the sero survey was done relative to when the peak was, the fact that the peak lasted, it peaked around the 15th of May, but then lasted for another month and a half. And that's roughly the period where the sero survey was done. But it went on for a while. And certainly Kerala was seeing in excess of 20,000, 30,000 cases for quite a while. The one thing that I'd like to say, and your readers to think about, is that there is actually no way of escaping a virus that transmits so fast. Ultimately, you will get infected if it stays endemic in the population, especially. So the only alternative that you have is to be vaccinated before you get infected, or to be infected before you get vaccinated. And ideally, all our public health aims at this point should be to get vaccinations out as fast as possible so that as much protection is available as possible to your population before they get infected. It's very likely that the scenario that will unfold over the next year, few years, etc., is that like other coronaviruses that cause variants of the common cold, this will also become endemic. What that situation will be like, we don't really know. To what extent does a prior infection, a vaccination protect the fact that you do have immune memory against this virus? Will it help you in later years? And it's very likely that it will. There are other components of the immune system that are not based on antibodies, but on the fact that on antibodies that are currently present, but the fact that it remembers and can create new antibodies when required. These are the T cells and the B cells. We know less about that component of the immune system and how that might respond over the longer term to a COVID-19 infection. So I agree. I suspect that the chances for a strong third wave are minimal. I agree that it's likely that pockets where people have not been infected so far and not been vaccinated are what we have to watch out for. Unless we have data at the level of states and districts at each state, we will not be able to tell which district might be more likely to have a surge in cases as not. But I doubt that something of the seriousness of the second wave will strike India at the moment.
Yeah, right. Thank you very much. But since, I would like to understand you made one point which is very significant. What you said was that we don't, there are issues about how this immune system works. I mean, there is nothing, which is very certain about it, because it could even vary. Even people who are vaccinated, got both vaccination, may still find themselves at the receiving end, because not much is known perhaps on this part. Would you like to elaborate on that?
I mean, it's really exactly as I said. We don't, for an individual person, we cannot predict what might be the consequences of an infection. At a population level, you can say that, look, a vaccination is certainly protective. It protects very well against death. It protects very well against hospitalization. A little less well against, an infection that may not do too well. There is a distinction between 1 dose and 2 doses. There may be a general booster effect if you have a third dose that acts. These broad statements we can make. But I don't think for any disease, and maybe Dr. Laria can correct me, that we know what component of an individual's immune response will determine whether they will have a more severe or a less severe thing. And we certainly don't know it for COVID-19. That I think is correct.
Talk only in a broader sense of the society as a whole.
Okay. Yes, at a population level, we can be fairly confident of the statements that we make, but it is very hard, or if not impossible, to make statements about which person, which individual might suffer an adverse consequence as a consequence of an infection.
Okay. Now I'll come to Dr. Sundar Raman. What's your view on this?
It's difficult. In some sense, most of the common things are stated, and those are well known. So I really don't have too much new to state, except to point out, let us say, the uncertainties that underlie our predictions. Because at some point, here is a situation where, never mind predicting the future, even predicting what happened in the past, predicting is a difficult word, but it is very problematic. We don't know with any great degree of reliance the number of cases infected or deaths that have taken place. And we say that we have looked at serosurveillance, and that also is incomplete data. So let me highlight some of the uncertainties that I'm worried about. One uncertainty is, if you are vaccinated, what is the risk of reinfection? We are now going with more or less a consensus that it is high, that breakthrough infections can occur, and they are called breakthrough infections, but they are less serious and less fatal, and therefore there is a high degree of protection. But breakthrough infections are there, therefore the spread is relatively unchecked. There is another question which worries me even more, and that is, what is the chance of reinfection for a natural infection? We are having, I am not able to hear a clear answer on this. There are many reports that have stated fair degree of reinfection. But in the nature of things, reinfection following a natural infection is rare. And there is not enough clear evidence of reinfection rates, and especially in symptomatic patients. So again, we have a major imponderable, because at some point we are not catching it completely through seroprevalence. And we don't know really whether reinfection happens. Now, some studies would say Delta virus reinfects people with pre-Delta virus infections. But others have actually said that Delta virus doesn't really cause it. And that, if it is reinfection, it is immune escape, as different from breakthrough infections. And that is an entirely different ballgame. And if there is a variant within a strain that does an immune escape that makes it more fatal, then we are in a deep problem all over again. So then we would be completely vulnerable to another way. So that is another area of thing that we don't know about. We also are seeing a relative stagnation in cases. We must remember that I've always been more curious about the coming down of the wave in November than the rise in April. It came down so dramatically in the first wave. And I see that somewhere the time it took from 40,000 to say 10,000, 15,000 was relatively short. Here you are having a much more gradual curve after 40,000. And to some extent, this notion of being endemic is already there. In some sense, a low level and a continued level of transmission has set in. And at some point, we are dealing with this, from which outbreaks can occur. And that depends upon the factors that Chandrakant had pointed out. But in subnational areas, outbreaks are quite likely. And we don't have an active disease surveillance response system, which is still looking at outbreak management over here. It's sort of given up on that, as if that we will manage a large wave when it comes, but otherwise public health doesn't really work. It's a very sad thing, because when you have flu, you have other pandemics that are equally likely to actually not go after the outbreaks and the endemic spread, is through public health measures. And in public health measures, we are really talking of case detection and being able to prevent chains of transmission at the local level. We are then in deep problems, because at some point, this is something that is, I think, another uncertainty. Even on the vaccination rate, I am afraid I am a little bit curious about the numbers that get tossed around. There is a number that the total vaccinations we have received is 70 doses per 100 population, which is very different from the number of what proportion of population has achieved at least one dose, where the number is close to 50%. And where the number of population which has achieved close to 2 doses is 20% of the population. So in some sense, if 20% of the population is a fully vaccinated population, then you have a very long distance to go to achieve it. And why does that 70 doses per 100 not closely relate to this is something that we need to see. And only 50% of the population has even one dose of coverage. Then we aren't doing very well with immunization coverage. And therefore, the protection that immunization affords against the recurrence of a wave is an important issue. And finally, given these likelihoods, given these uncertainties, we may conclude that the necessity of the expectation of a large national third wave has decreased, but the necessity of preparation for pandemics has increased. In the sense of so many uncertainties that shroud this, and so many ways in which you can have breakthrough infections, you can have immune escape, you can have subnational breakthroughs, you can have new viruses coming into the situation, that at some point the concern is, have we really learned any public health lessons or any lessons in the organization of care from the first pandemic? And there, the news that people like Chandrakant is giving us is dismal, that he's saying actually nothing has happened. I'd like to think that there is some experience of dealing with it that has got embedded, perhaps not intentionally, but has got embedded in the medical fraternity, and there is a much better skill for managing with the hospital care if it comes to that. But not wide enough, not broad enough at some point. But yes, I think these are my main.
Yeah, thank you very much. I'll come back to you. I think the question really about vaccination, I'll come to Sridhar for that. Before that, I would like to go to Malini. She has a specialization on some areas which normally kind of are left out. See, the focus on medical instrument, medical pharmacy and other things are very important. And I would like to see this whole thing from that perspective. How prepared are we? Because we heard Dr. Chandrakant is pretty dismal as far as public sector participation is concerned. Of course, I would slightly differ in this part of southern parts of India. Actually, the infrastructure is slightly better, government. But I think as you move north, it's certainly not as good as it should be. How do you look at the whole thing?
So I'm not really equipped to speculate about whether there is going to be a third wave and when that might happen, what form it would take. But I think that the other panelists have addressed that question quite well, and I think there is a broad consensus among all the experts that if there were to be a third wave, it would probably not take the form or the scale of what we have witnessed during the second wave. But I think that there is also agreement that many of us remain vulnerable and that the pandemic is certainly far from over, and therefore there is no room for complacency. So since this webinar is really talking about preparation, I feel that there is a lot of unfinished business after the devastation that has been brought on by the previous waves. Pretty much all of the government's efforts that were made were during when the crises hit. And that has actually ended up costing lives, whether that is in terms of the lack of coordination in the manufacturing and distribution of essential commodities like medical oxygen, essential medicines, creation of beds that are equipped with critical care, or even the ramping up of vaccine manufacturing. So basically, there was a lack of foresight, and I would say that both the central government and many state governments are implicated. And one of the chief reasons was because there was really a lack of a public health approach. And those, unfortunately, who were worst affected were the poorest and those that were living in less resource states, or where the state government was intent on downplaying the extent of the wave. We also saw instances in which the government actually brought about some policy measures even after, but unfortunately this was too late. So for example, there were some measures that were done after the second wave had swept through the country. One of the good examples is price controls on oxygen concentrators that were implemented way too late. And this was also done only under the pressure of the Delhi High Court. And after the numbers in Delhi had subsided, and across the country even. But here the formula that the regulator used, which was based on a capping of trade margins, was done it was deeply flawed and eventually legitimized profiteering rather than providing financial relief to the public, and therefore has set a very bad precedent, which was carried forward into trade margin capping of other devices. In the case of medicines, even though government intervention was sorely needed, there was absolutely no action. There continues to be no action from the government, in spite of the fact that many of these COVID-related drugs remained unaffordable. So I would say, just to sort of wrap up, that there is a need to bolster the policies and regulations that were needed to have been in place throughout, and to do more towards alleviating the hardships that were faced in the aftermath of the waves. Right now, we have an instruction from the Supreme Court that says there have to be ex gratia payments to families that have lost members to COVID. But these sort of measures would also hold us in good stead for any future wave, because these systems really do need to be in place. And there are obviously a lot of issues, but I will just flag maybe 4 areas. One is looking into the process through which the regulatory approvals are being granted for both drugs and vaccines related to COVID. The second is bringing a more scientific basis and transparency to the vaccination policy, because vaccines, of course, are a very big tool that are being used to address the pandemic. The third, I would say, is a need to fine-tune and correct the COVID treatment protocols. And the last is closing the gaps and loopholes in regulating charges for COVID treatment in private hospitals, and catching up on the enforcement, because there is a need even now to look back and maybe conduct audits, put in place grievance redressal mechanisms, and so forth. But if you step back and look at a slightly bigger view, I think it would be equally important for the country to develop a longer term vision in terms of how to provide affordable healthcare. The pandemic has, I think, undoubtedly been a bonanza for many segments of the industry, all segments of the healthcare industry, from whether they're labs or testing, test kit manufacturers or treatment providers and pharma companies, and also corporate. Therefore, this is unfortunately, very counterintuitively led to a shift towards intensifying privatization, and much more power has been granted to the industry in terms of advocating for its own interests, which are not necessarily in alignment with public welfare. So there really has to be some application of the lessons of the last year and a half towards creating a roadmap towards more equitable access to healthcare and reversing the current trend towards corporatization.
Yeah, thank you. Look, one point I would certainly like to ask you, whether you want to answer now or we come later. See, the question is, when we talk of big policy issues, oftentimes we even forget minor issues. The way even the oximeter pricing People are running helter-skelter. The height of the pandemic, it ranged anything from a few hundred rupees to a few thousand rupees. People didn't know what to buy, whether they should have one at all, or how effective it is. These are smaller things, but it really, at a time of a crisis, hits hard. People were actually running for oxygen concentrators. I mean, there are a whole lot of things available. You can actually buy oxygen concentrator at home. You can keep it. There are all kinds of things coming up that time. There are other things like medicine, remdesivir. People were queuing up overnight, actually, to get few doses of remdesivir because it was left to them. Go and procure yourself. I can go on and on. We'll talk about this. Please think about it. I'll come back to you. Meanwhile, let's go to Sridhar. He's waiting for us. Sridhar, you've been very, I've been reading you, I've been also watching you on TV and other channels. You've been very skeptical about the way the whole vaccination program has been going. But now it appears that single dose, at least, about 75% or more has been delivered. The 2 doses, I think it varies somewhere between 20 to 30%. So where do you see this vaccination? Are you slightly now, your criticism, is it slightly moderate now? Because even this looked a bit unachievable earlier.
Yeah, but first, let me, from the presentations made earlier, I think about the vaccinations that I wish to talk about, 2 things were very striking. But before that, let me characterize, the whole approach to the pandemic, policy approach to the pandemic has been, I would like to use the analogy of using a sledgehammer. That has been the approach of the Union government from the beginning, and the lockdown has been the only thing that has actually been done effectively. There has been no other. Now, if that is so, 2 things I want to take up from the previous, what has been said previously. One by Dr. Sundaraman about the imponderables, the many imponderables, and Dr. Laharia's point about unevenness. You need to have, so both these require a nuanced approach. That means the imponderables require you to provide for adequate safeguards in terms of, developing the vaccine and having enough and doing something about it as a protective measure. The unevenness requires you to adopt a nuanced approach, which means a targeted approach to those who are particularly vulnerable and so on. And again, here I would draw, for example, what Dr. Laharia has been passionately writing about in the last few weeks about the need to get children back to school. And you need to, therefore, for that, the reason I'm citing this is you need a nuanced approach to ensure that children get back to school. You need to ensure that the environment at home is conducive for the child to go to school, which means those who are vulnerable at home need to be protected. So from a vaccination standpoint, what does this mean? This requires you to have an approach that is nuanced to recognize these things and pay attention to these little things on the ground. But what is happening today? Let's now come back to what we have achieved in vaccination so far. That 70% and above figure is a little, it's not, I would say it's a little dubious to go with that number, because if you have to vaccinate your entire population, you need something like about 1,870 million doses, and you have delivered something less than just about half of that. So you have actually delivered only about 50% of the vaccines that are there. Now, why is that important? That is important because we don't know the effectiveness of the vaccine, how long they will offer immunity to people, and how long and when they will start waning. So those are the imponderables. Now, in order to address that, you need to have a stable policy regime that ensures that the supply of vaccines is maintained. Now that doesn't look very optimistic. I mean, that picture. I'll tell you why. For example, since June, July, we have scaled up vaccine delivery. There is no doubt about that. And in that sense, I do admit that things are much better than they were in, say, the pits of April and May. But they're much better. But still, if you look back, it is still very unstable. And for example, in September, we delivered about 7.88 million doses per day. But in October, the first 15 days of October, this has dropped by about 30%. We are down at 5.48 million doses per day. Now that is, these are not things that can be. So there is no stability in this approach. But even more importantly, we are relying on just one vaccine supplier. And mind you, again, one of the other imponderables is that at some point we may need the next generation of vaccines. Where are they going to come from? Do we have any plans for those? And so there are very many imponderables in this whole thing. And as far as the vaccination drive is concerned, we seem to have plucked the low-hanging fruit. And it's going to become more and more difficult to, like, for example, I refer to a story in the Mint today, which has a very attractive graphics, which shows that vaccination rates in the poorer parts of the country are much lower than in other parts of the region. Which brings me back to what Dr. Laharia said, that you need to have, if you have an outbreak which is localized, you are not prepared for it. You are exposing, because of your lack of progress in vaccination, you are exposing those people in those regions to a third wave or whatever wave that may come in the future. So I think the vaccination drive has many things that are wrong with it, and that have not been addressed till date. And the example of Covaxin is very much there. We don't. In August, I remember they said there was going to be an exponential increase in supply. It doesn't seem to be coming at all. And so the other thing, now we are talking about exporting vaccines. Now that export of vaccines is actually, it is just, what shall I say? That's not quite right. We are only allowing Serum to comply with its contractual obligations that it had promised to the COVAX, to supply COVAX, for which it had received money well before even the government had even thought of vaccinating people in India.
The global alliance.
Yes. So that is going to be there. So I suspect, in fact, I suspect the slowdown in vaccination may perhaps be linked to this shifting of supplies to meet those contractual obligations.
Okay. Well, what percentage you think, how much it could impact? One doesn't know, or is there any idea about it? What percentage of this they have to under the obligatory?
That I don't know. I mean, I'll just have to go back to the. But there was at least some 300 million doses that were to be supplied.
Yeah. Okay.
At that point, quite apart from the fact that that Serum has also entered into contract with to produce Novavax, the protein-based vaccine. So its capacities are pretty much stretched.
Yeah.
And to rely on just one source of supply without doing anything about trying to expand your base, not forget about newer generation of vaccine, but I mean the existing ones, is I think quite foolhardy.
Yeah. Okay.
I'll leave this at that.
Yeah. I'll come to Dr. Laharia. We could even describe you as some kind of a detective. We try to find out which corner the virus is lurking. But to find out, I think you use genome sequencing as one of an important tool. So the government is supposed to be collecting the sequencing samples from various states and districts. I'm sure there is certain method in that. There is an institution also which does this. Is it happening? Is it happening to your satisfaction? Do you find that we are doing enough to track early to know changes or signs of how this virus is mutating or changing, because it's not going to stay stable. That's what I learned from all of you experts, that it's not going to keep quiet. The virus is not going to keep stable. So, are you sanguine about it? Yeah.
On genomic sequencing, I think India has made some progress. What we need to remember that the target which was initially set up of 5% of the total positive cases will be genomic sequence, which was unrealistic. Actually, it is just 400,000 daily cases. Essentially, 5% would translate to 20,000 genomic sequence in a day and 600,000 in a month, which is impossible, not required, expensive, no facility can afford, no country can afford. So that target itself was unrealistic. Of course, that is a process which requires not only resources, but technical expertise and laboratories. And India has made progress on that also, from 10 to from almost limited capacity to 10 and then 28 facility. And now some genomic sequencing is being done. Of course, number is less, but globally also many other countries are not doing that kind of genomic sequencing. Entire genomic sequence takes time, cost. So what they do is smart sequencing, which essentially means looking at a specific probe, and that's what should be done. So India is doing has improved, and I think for setup like this, where resources are scarce and we need to intelligently use resources, country has made progress. But the key point is that are we doing that in timely? Are we utilizing that data to inform decision making? How fast we have changed those processes? Those are the things which we need to remember. So, but I personally think that has made a progress. But I quickly want to go back to 2 points which Dr. Sundar made and the other panelists also highlighted. One part is that this number, that 70% of population received one shot, or whether 35% fully or 20%. What is this? Actually, this shows the that how we are using data in this pandemic. And this shows that we do not fully always use or convenient use of data for pandemic response. 70% is true when we say that our denominator is adult population. 70% of adult population has been vaccinated, which is 94 crore. But if we say that entire population, then the number is less. Then we start using entire population, what proportion has been vaccinated. That is, though that put government in a bad light of 20% total population fully vaccinated. But we also need to remember that there would be some population which would never need vaccination. I don't think children younger than 2 years would ever need vaccination. Similarly, children younger than 18 years all may not need vaccination. So our denominator is never going to be that way. So it shows the problem at the level of data. The data is not collected, then data is not shared, and then data is not correctly interpreted. Every different set of individuals start utilizing their own set. So we need to pay attention on that continue to be. But I want to also make another point in which why I argue that nothing has changed in India. So I am doing a separate, as part of my separate work piece I'm doing, on which I studied that how India's healthcare system has evolved from independence till now. So at the time of independence, India had a thought of a developing healthcare system. And when we talk about healthcare system, it talks about public health services as well as medical care system. And the primary healthcare system in the country was designed to deliver both types of services. But over a period of decades, the primary healthcare services were started to be identified something which deliver only public health services. There was no medical care system. And then this medical care system was largely restricted to district level facility. So we broke down from health into two separate parts of public health and medical care system. And that is the challenge, that today India's primary healthcare system recognizes only delivering public health services, and public health services cannot work till the medical care is provided to those people. And that's one challenge. But my another bigger thesis is, and that's why the pandemic response has not been successful, that whenever public health system fails or public health services are not available, it inadvertently results in medicalization of healthcare system. And in this pandemic, the healthcare system has been medicalized. Now people have started, okay, what we need is a medical care. They are more concerned about medical care. The government has strengthened medical care system. There is an entire 23,000 crore allocated in second wave, is mainly focused on strengthening infrastructure, which might never be needed. The oxygen plants or the ICU beds or pediatric care. and those kind of pediatric care which might not be required for routine care system. So in this pandemic response, public health should have received far bigger attention. But my sense is that it has further medicalized Indian healthcare system, and that's where a bigger challenge is. Even if like somebody need to examine the policies which were announced from start of the pandemic till now, and there were many promises on strengthening public healthcare system or public health services, both. Those are two different, and both promises were made on both. Only if those promises are fulfilled by policymakers, India's healthcare system would be far better.
Okay, thank you. A very important point. I mean, a very nuanced one that, we are medicalizing and not increasing the public health services or public health systems. That makes me wonder about another point, but I'll come to that. Before I want to ask Professor Menon a question. Look, here we know, like Dr. Lahiriya is saying, you're also agreeing with him that, even if there is a third wave, it may not be as as devastating as it was. Possibly, there are many reasons which you gave. But what about how close or which is the tipping point? I'm not asking you to kind of start, speculating about it. But what do you need? When do you actually know, as a scientist, a certain tipping point has come where you are trying to put the genie back into the bottle, at least from pandemic, it can turn into an endemic?
Sorry, I missed the last bit of what you said.
Yeah, I'm saying where it can turn from a pandemic to an endemic, where you can.
That's
where
hard. I mean, the definition of an endemic is when your reproductive ratio sticks at 1, where the total number of cases sort of fluctuates a little bit above and below. And that, I don't think we're there yet. I think we're still seeing some level of cases, and whether there will be ups and downs, exactly as was pointed out. But I suspect that in the next 6 months to 8 months, probably things will change, and then we will get into a situation where we will know that we are in some sort of endemic state. I think right now there is some distinction between, as I said, the North, where effectively much of the North has had a very high burden of prior infection. And that, I think, is what will ensure that cases don't rise too much. It's a little, exactly as you said, it varies a little bit across the country. The South a little less, the North a little more. And is there a tipping point in terms of when we should open up and how we should open up? I would put that tipping point at about 80% seroprevalence, derived both from vaccines and from prior infection, with the prior infection probably being a little more important. That's what our model sort of suggests. In fact, beyond about 75 to 80%, you don't really see, if you open up at a fuller level than you're doing. Open schools, for example, it seems to be fairly safe to open schools. As was pointed out earlier about this question of I think Mr. Sridhar pointed it out, about the families of school-going children and prioritizing them in a sensible, to think about vaccines and how they might have maximum impact. So we pointed this out, that at least in our models, it made sense to prioritize families of school-going children while sending children to school, and to make sure that they were vaccinated, because the sort of consequences for mortality of a COVID-19 infection really come from elderly people. So especially target people at home, but then send children to school. And the sort of suggestion that came out was, don't test too much of children, because you do know that they will be infected, but you know that typically they will suffer, most of them will suffer no consequences at all. They may not even know that they've been infected. Be very careful in looking for symptoms. So try to look at children. So any symptoms of MIS or anything might be suggested, but otherwise don't oversaturate, because that is a large expense, it's a large administrative load that you will take for very little that you will get out, really. That's my personal opinion about what ought to happen. I think the important part of it is to protect families of school-going children on priority, and that would be a sensible thing for a vaccination campaign to actually do.
Yeah, so what you're advising is basically a more nuanced approach to the policies and broad sweep, which is what we are saying largely. Another point I would like to ask you right now, see, since we are also looking at what happened, it's always helped to look behind, look in the past to see what we could do in the future. It always helps a kind of a guideline. If you had to compare the two models, which is strikingly different, one is a Kerala model of managing the COVID, and the other one is Uttar Pradesh. Kerala was first of the block. It actually controlled very well. In fact, the first two phases, it was managed very well. There was no pressure on the infrastructure. Even the death rate continues to be very low as compared to the rest of India. Mortality rate has been very well managed. But then you have, there are people who, there is a bunch of professors, IIT professors who are saying now that here is the UP model, which actually started, peaked very quickly, and then it ended very quickly as well. How do you compare the two? Because the infection continued for a while in Kerala, when the rest of India has actually come below a certain threshold. 50% of the case load was still coming from Kerala. So that made many people wonder whether the Kerala model actually worked. How do you look at these two issues?
So my point of view is that you should first decide what constitutes success in your opinion. So in my opinion, success would be keeping the number of cases as low as possible. So overall population seroprevalence as low as possible, keeping the health system unstressed. So you never reach a stage where you are running out of ICU rooms or oxygen cylinders. And 3, attention to data so that people can trust the numbers that you're putting out. So if you say that, look, I'm recording so much of mortality, my cases are so much, etc., there must be some relationship of that with reality. On these 3 grounds, you can compare these 2 models and then decide for yourself where success is. If you look at the overcounting of cases in Kerala, it's a factor of 6. If you look at it in UP, it's a factor of 100. If you look at mortality, where Kerala numbers are, again, nobody does a perfect job with mortality, but they're a little bit more to be trusted based on the reporting that we've seen in terms of excess mortality across much of UP. In fact, there are districts of UP which showed no mortality at all. So surprisingly. So that's the second point. And never at any point, as far as I know, maybe in Ernakulam for a short period, were you seeing hospitals, sort of ICU units full. But I think over much of Kerala, it's true that the health system was never strained at that level that we were seeing, for example, in images out of Lucknow or other places. And of course, a vast part of rural Uttar Pradesh, of last part of rural India, which was not served. The television cameras are not pointing in that direction. But there are records of deaths and people dying who just could not access any sort of medical treatment. So I think you first, before you have the discussion, you have to define for yourself what is success. What do you consider to be success? And if it's only, look, I have seen so many cases going up, etc., and then they come down and now they're very small, that's hardly success. If I didn't record any cases at all, I would be infinitely successful because COVID-19 would not have existed in my state in the first place. But if any reasonable epidemiological measure of success, according to the 3 points that I pointed out, would suggest that Kerala is in an absolute sense doing better than, for example, UP or some other states. It's not very pleasant to be able to compare states. Ideally, every state should have done well. But every state didn't start from the same initial condition. Kerala has paid more attention to public health in the past. UP less. UP is a large company, much larger in terms of population, in terms of it has its own unique problem. Every state in India has its own unique problems that determine at what point it started out for. So I would not use this as a reason to crow for Kerala over something else. I would just say that, look, we have to understand where the problems are in each individual state and address them as fast as possible and not sort of assume that this is superior to that. But along with that, we should not fool ourselves about what is reality.
Yeah, sure. I get the point. I'll quickly come to Malini. I asked the question earlier to you. In terms of hospital infrastructure, we saw a kind of crisis in both first and second phases. Of course, Dr. Lahiriya said nothing much has improved, but if you can point out specifics, of course, you did list few things earlier, but in terms of more the way the consumer should be looking at, the way an ordinary, person who's getting hospitalized should be looking at, is there any change? Do you see anything like private hospitals? Yeah.
So you had said, that many of the medical commodities had become completely unaffordable, were excessively priced during, especially the second wave. So those were everything from oxygen cylinders, variety of drugs and therapies used in COVID treatment, and even the cost of services like ambulances had really gone up hugely. And I would say there are broadly two factors that were driving the increase in prices. The surge in the number of cases meant that there was obviously a spike in the demand, and therefore shortages were occurring because of the lack of preparation. And secondly, the suppliers were taking advantage of that situation by profiteering and therefore raising the prices and controlling the supply again. And here, I would say that also another contributing factor is that many experimental treatments were being used irrationally, and there were rampant prescriptions of unproven therapies, which also kept up an artificial demand, which has pushed families towards running around to try to get access to them. And that really brings me to some of the points I'd just like to make quickly on the regulatory approvals of drugs and vaccines, which at the moment continue to be marred by a remarkable lack of transparency. And we just don't have any idea in many cases of the data or the rationale on the basis of which the decisions are being taken. In the case of drug approvals, there are many drugs that should probably have had their emergency approvals revoked, like favipiravir, which has failed to meet the primary endpoint in the phase 3 trials. And the regulator ought to have reviewed the license based on the current scientific evidence. Yet this is one of the drugs that really became blockbuster and made the highest sales in the last year that exceeded even some of the other medicines like remdesivir. Similarly, the permissions that were given to other drugs for COVID, like itolizumab, have been mired in controversy, including for multiple inconsistencies in the way the data and the trials were conducted. And that also again calls into question the existing approvals for these drugs. And there are, it's also the fact that many of these drugs have never received recommendations for inclusion in the National Clinical Management Guidelines for COVID. So what really is the meaning of a restricted emergency use approval when it is not being officially recommended for use in COVID treatment? There is also another drug that is currently being evaluated, molnupiravir, which again, the data are unpublished. There is a lot of opacity around the results of the clinical trials. It does not appear that this drug is going to be going to be particularly effective in moderate patients, judging from the limited information we know about the trials that are being conducted on moderate patients. And therefore, its utility might be extremely limited just to, if we're going by the company's press releases, it might be limited to just mild patients or high-risk patients or unvaccinated individuals. So is this going to become another case of, very highly selling medicine, similar to favipiravir, but for which we're not entirely clear about the basis of the decisions and the data behind it? I just also want to maybe make a short point that during the whole pandemic, what we have seen is that the CDSO has really made a sort of a mockery of the law during this time. So it has actually made up terms like clinical trial mode when it was, providing the emergency approval for Covaxin, for example. And this is a terminology that doesn't really exist in any of the laws that apply. And now CDSU has kind of converted this into a habit to color outside the lines of the existing laws. And this is clearly setting a disastrous precedent. When it comes to, obviously this lack of transparency extends also to the approvals for vaccines, but vaccines are not just, the vaccine policy is determined not just by regulatory approvals, but also other high level committees. And I would say it's deeply frustrating that committees like the NECVAC and the NDAGI are making these decisions about vaccine procurement, rollout, And there is obviously some influence also over the regulatory approval process, which is being asserted. Even though we know that in many instances the approvals are going through without sufficient data. Some of these data are never coming out in the public domain or being published. I would say that we have some interesting cases where a respected member of the National Technical Advisory Group on Immunization has been appealing publicly for more data to be shared, for studies to be undertaken to inform the decision-making on vaccines that are currently in use, and also voicing her opinion on various important decisions. But interestingly, all of the members of this committee are bound by a confidentiality undertaking that is supposed to be at least 5 or maybe 10 years long. And there is another member of the same committee who currently does serve as the chair of the DSMB of Serum Institute's trial for Covishield in India, and has received remuneration by this company and has been part of all the decision-making processes, even though this is the sort of conflict that should have been disclosed publicly and would technically disqualify his participation as part of the committee's own conflict of interest guidelines. So, that's in terms of the process through which vaccination policies are being made. But broadly, in terms of how this impacts on, vaccine recipients, there is a lack of patient information regarding, the data related to the vaccines, the fact sheets, and product information. Literature is not being updated even on the CDSCO website. Information is not being provided to recipients for how they can approach the government in case of an adverse event. And the adverse event monitoring and reporting system, of course, is a very weak mechanism. It has been, in spite of a couple of a lot of pressure on our part, reporting many cases of what we thought could be suspected serious but rare adverse events of Covishield. There has been only one case that has recently been acknowledged of thrombocytopenia syndrome in India that just happened recently, in one of the cases where we had to work pretty hard to get this case even reported to the government. And the investigations in general are lagging. They're very poorly conducted. And the government's approach has been to treat those who suffer from serious adverse events as basically collateral in the whole vaccination scheme. And there is, of course, no compensation mechanism in place. So, so I would say, there is a lot of scope in terms of improving the way that both policy decision-making is taking place related to COVID drugs, vaccines, and also the regulatory approval process.
Yeah, thank you very much. I think you made a whole lot of important points, which I really appreciate, because it's these are the learnings which actually need to be addressed, and that doesn't seem to be happening much right now. See, this one focus which we have to, there's a lot of concern about it. Professor Menon also brought it about, is about children. It is important that children go to school, because it's not just education. Dr. Lahiriya has also been pointing out, it is also about nutrition and a whole lot of other things is important, because it's not just urban, a whole lot of rural children are affected. So, if I go by the science of it, it appears that younger population have better immunity. They're able to withstand infection better. They have better physical barrier in terms of airway epithelial cells or macrophages and antibodies, T cells, B cells. These react much faster than them. These are various things are picked up as far as while reading what you experts write on that. But still, there seems to be no education about all these issues. There is a lot of hesitancy there also building up. Is there any way, or what are the ways you think this could be addressed? If others also want to jump in, I would like to ask Dr. Sundar Raman. I would like to pose in this question.
Yeah, I think that on the whole, throughout the pandemic, the health communication strategy has been inadequate. A lot of it has been focused on a certain stereotype messages using celebrities, not really getting into engaging with different questions that people are facing and being able to show uncertainty and being able to discuss what we need to do to take this forward. And therefore, there are a lot of fears around. Some of them are genuine, some of them are exaggerated, but people have made a fear. I have been on a number of local television shows where a big concern that is established is that, okay, we don't know so much about the disease. If the child gets COVID-19 now, maybe long COVID will come, and you may say that right now the child is safe. But in future, that should I take the risk? And there are no simple answers to the variety of questions that are coming forth, except that you do need to really be explaining much more about what we need. There is, I think, a very high degree of stigma and fear. And even at the rural population level, the certain local denial of the pandemic, certain as a mechanism of coping with it, and which also affects people coming forward to report the disease, to get tested, to get treated, etc. Now, I don't know whether that's the specific question that you were looking for, but the major issue that I would like to use this occasion to flag is the need to be able to engage in communication with people, not only through primary care team, to be able to actually have an active outreach program, which is very much part of the control mechanism which we put in place. I think a very important aspect of that. And that would have made a very big difference in many stages in the campaign, especially in preventing spread. Yeah.
Yeah, I think Professor Menon, you want to say something? Yeah.
Just one very quick point about children. And that's the following, that if you look at seroprevalence in children versus adults from the sero survey, they're not that different. So even by locking them up effectively for about 18 months, you have not made a difference in terms of the children contracting the infection. That's an important point to convey to people, that this thing that, you have protected them by keeping them inside the house, they've not caught the disease. That's not true, because that's not true from the numbers. And that's one part of, I think, what ought to be communicated as part of this. Yeah, sorry.
Yeah. Before I go further, I would like to invite, questions from viewers. There is one question which has come from a viewer. He's asking, I think anyone can answer, how long the vaccination in general is effective? Is it correct that we have to repeat the vaccination at regular intervals? This is the question coming from Krishnamurthy Sankarnarayan. Who would like to take it? Dr. Laria?
Yeah, so the short answer is that we definitely don't know how long the protection will last. But going by current evidence, we can say that a person is very likely to be protected for 1 year minimum, possibly for longer. But we also need to factor in another epidemiological fact, that this vaccination is happening in a situation where people are exposed. So in that setting, it could last really long, but 1 year is a minimum time. The second point to remember in this is that this is a SARS-CoV-2 is a respiratory illness, respiratory virus, as we say. We know that majority of respiratory virus in the long run require a booster. Not all, but majority required. So we might need a booster shot or a revaccination of either some or a few, or we don't know, but a second booster shot might be required for the population in the longer run, but that is not on the table as of now.
Yeah. Okay. Before we go further, I have a small announcement to make. Recently, at this website, the Federal. We placed our premium product, the 8th column, behind a paywall. Our website, www.thefederal.com, is still 95% free. We have adopted the freemium model by placing only 5% of our offering behind the paywall. Rest 95%, I reiterate, 95% continues to be free. The premium section costs rupees 365 a year. In other words, only rupee a day. Type in www.thefederal.com and subscribe to the section which brings you articles and ground reports that you would not, I'm sure you won't find in other publications, because we really choose those articles. Now I'll come back to Professor Menon. Here is something we know. I really want to discuss about the COVID treatment protocol. I would pose this to both Professor Menon and also to Dr. Laharia. The treatment protocol was evolved in the first phase with a lot of trial and error. Even anti-Ebola drugs were used, even combination HIV drugs were tried out. In the second phase, what we saw is the need for oxygen. Suddenly, people are running for oxygen concentrators, and that became a requirement. But we really don't know what the third wave would be, whether it would be at all, and how the virus may mutate and what may be its character, and therefore the treatment protocol. So how is this issue likely to be handled? I mean, do we see once again the same kind of thing, or are we much more sanguine right now about the issue than we were earlier?
Okay, that's a hard question. I think probably Dr. Laharia would maybe in a better position to handle it. The answer is we don't know. We don't know if the virus mutates into something that's very different from what it is. It might call for new thing. Already we know that the symptomatology shifted a little bit, I think, between the first and the second wave. I think you were seeing more diarrhea, more conjunctivitis, and somewhat more unusual systemic consequences. But I'm not sure one can really answer that question of what is it that might happen in the future, and can we prepare for that without knowing it? I don't think so. But maybe Chandrakant has a different point.
No, I'm not. Yeah, that's the point which I'm again trying to. From the available information only we can go. Nobody can predict what might happen. What's the nature, we don't know. But again, the protocols, are we better? Is the treatment protocol now better than what it was? Dr. Laharia.
Yeah, so it might sound a little rhetoric, but if the data has been used conveniently in India's pandemic response, then science has also been used conveniently in India's pandemic response. And that has been a challenge. But when it comes to standard treatment guidelines, I think the current standard treatment guidelines for COVID-19 management are fairly science-based. And it has followed the entire life cycle in this pandemic, 20 months. I think I agree that in the beginning of pandemic, some of the investigational therapies were used, which were not proven, but that's the right approach because we did not know, and with the use of those therapies, some lives could have been saved. What has been wrong in between, that when evidence emerged, but still India continued to use some of those therapies, and one of the reports which we discussed in the earlier section continue to say that because of particular use of particular unproven therapy, they could reduce the mortality. So that is something unscientific. But in short point is that in the beginning, some therapies were used, given early approval. I see it's arguable, but it has potential because we did not know, and science works based upon hope that it will work, and first do no harm. That's what Hippocrates, the father of medicine, said. So they thought that it might provide some benefit. Somewhere late October, November, when we started seeing a large body of evidence, including on use of convalescent plasma therapy, which continued from November 2022 till mid-June 2021. I think that's an area where more science-based approach could have been followed. End of June, Indian government has released guidelines which are fairly evidence-based. If we can continually update, use emerging evidence, I think that will be fine. So that's where some progress has been made.
Okay, thank you. Here are some more questions from the audience. Actually, it's not a question. I think everyone is very concerned. The question again is, how long is the vaccination effective? For how long? I mean, that's a question which is constantly coming on the screen. I think this question has been already answered. And there is another question. It's not a question, it's an observation. Very sad that data is not shared for further research, etc. I wonder why don't the government of India realize the blunders? And the other one is, of course, this is a different question. When can we expect Moderna vaccine to come to India? Well, that I think nobody can answer, but I can certainly raise a question from this. You see, of all the three kinds of vaccination we know so far, one is adenovirus, the other is killing the the first method is what I think Covaxin follows, and you basically kill the virus, killed virus. Second is adenovirus. Third is, I think, this Moderna's RNA based. I mean, this apparently is the most modern of all, which can be quickly tweaked to phase any variant which may cause harm. So your vaccination actually can improve with the help of that. That's what so far the reports are suggesting. I mean, is there anywhere we are near that, or we are still with the first type of vaccine manufacturing process? Is there any progress on that? Are we seeing any light? Anyone who want to take?
Yeah,
yeah, Sridhar, you want to?
Yeah. I think we have been. I think because of the way we have gone about. We started with a lackadaisical approach to vaccination, and then we didn't bend our ways as we went along, and we didn't develop a bouquet of vaccine technologies or different platforms. We didn't do that. And we still don't seem to be on that path. And that is worrying, because what we have is an inactivated virus platform, which are known to have production difficulties. There are problems in scaling up, which should not be surprising about what has happened with Covaxin. And so therefore we remained on that. And the other platforms we didn't develop. In fact, the original sin was committed several years ago, when we completely wound down our public sector presence in vaccine capability, manufacturing capability, and therefore we are paying the price today. We have not developed the other platforms where we could, there are many other smaller biotech companies in India which have been doing some work. We haven't built an ecosystem to help them scale up capacity and develop these technologies further, and that is certainly a problem. And we are not there in any of the other platforms. mRNA is said to be. I mean, all these are preliminary. For example, one of the reports coming from Israel, which is not yet conclusive, is that the mRNA vaccinations effectiveness also drops much faster than the other vaccine. I mean, I don't know how far these results are conclusive in terms of evidence, but this is supposed to be one of the things. So it makes sense to spread your bets and have developed different platforms, which is what China seems to have done.
Okay. Dr. Sundararajan, here is another aspect which is very important: vaccine hesitation and how to beat that. In Tamil Nadu, what happened was a medical doctor approached and told a farmer that he should get vaccinated, and he challenged him, saying that, look, if I get vaccinated, I may fall sick, and therefore my farm work would suffer. So he asked him, quid pro quo, would you like to work in the farm? He took the challenge, and the farmer got vaccinated. Of course, the doctor hadn't go to the farm, luckily, but the farmer eventually took the shot. Now, how do we deal with hesitancy? There is still seems to be some resistance in some places. Some other countries have dealt with it. Yeah. France has dealt with vaccine hesitancy by imposing sanctions that even threaten job security. US is more liberal, and therefore we see that it's unable to tackle effectively. What would you recommend here?
one of the things that we should not do is to start quickly jumping towards mandatory, obligatory, compulsory, and sanctioning for achieving overcoming hesitancy. That will seriously worsen the problem, compound it, and make it very difficult to handle. The vaccine hesitancy that we face in India is different from the nature of vaccine hesitancy. Broadly, there are overlaps that you face in the West. A whole lot of this vaccine hesitancy can be addressed by good public outreach programs. We've known that with measles. We've known that with all the advantages. Even today, if an immunization program for children is not accompanied by a good outreach program, by the ASHA program, by the entire system of village health and nutrition days, you're going to objective problems related to poverty, deprivation, related to lack of awareness, related to latent health demands being there in a high way, that are amenable to achieve, to being addressed through very active, proactive public health outreach programs that makes it convenient for people to come and presents to them large sections of the population who have taken the vaccine and have done well with it. So as the numbers of people within a community who are accepting vaccine increase, there will be further increase in vaccination and you have an entirely different outreach. So I think the vaccine hesitancy issue over here needs to be really addressed. The more vulnerable the section, the more marginalized the section, the more stigmatized the section, the more there is likely to be hesitancy. This is not again the problem of certain hesitancy where you have persons who are a certain insisting on natural health approaches vis-a-vis technological interventions and therefore towards vaccine. That's the different issue. Here, what we are facing is really being enabled to go for the vaccine. There are times when they will have a fever or 2 days of fever and they will be unable to work. That requires degree of support and help. So a whole different approach to it. And I think that many states, like Tamil Nadu in the beginning, had a major vaccine hesitancy problem. It picked up. It picked up because it sort of recognized and put its public health act together and went about it the whole way. So that's the whole thing. Of course, this approach that we started out with, you register in COVID and then you come and get vaccinated, that was going nowhere. And that, of course, in practice, nobody very on the ground, people were more sensible than what was the policy projection of how the policy will roll out. I think vaccine hesitancy is still a major issue, but there is an hesitancy towards getting tested. There's an hesitancy to accepting spread in the community. So it's part of a complex of awareness, health-seeking behavior of how you need to look at this. And also confidence measure. It's not helped that we are having a whole lot of changing statements, confused statements about when you should take vaccine. There's clarity about side effects. All of these things together help. But largely, this is in India a problem that can and should be managed with proper, what is known as behavior change communication or health education. Really what's the core at it. Good old health education will make it.
Yeah, I want to make another point here. You see, how to bridge the gap between vaccinated and unvaccinated. It's a related issue because those who are unvaccinated are vulnerable. And some studies in Europe and Britain have shown that those who are unvaccinated, 80 to 90% of them actually could end up in hospital. And the mortality rate is also high among unvaccinated as compared to vaccinated. I mean, this is based on studies there. That's an important point because I don't know whether enough studies have been done here or the data on this here. One more question. It's an important question. Maybe it's important from the point of view that we need to know what happened. is the undercounting of death, which was very evident during the second phase, especially in the states in the north. Of course, everywhere it happened, like Professor Menon pointed out, but in some states more, some less. A handful of investigative journalists did work on this. But correct reporting is required both for obtaining a closure for families and who had lost their loved ones, and for public policy administrators for preparing themselves to face the next pandemic. Do you think anything is happening on that front? Is some lessons learned? Are we trying to really put some processes in place? Is any awareness anyone has heard? I would like to know. Yeah. Professor Menon, you want to say?
I think the one prerequisite is just to admit it, which I don't really see. So I think that an understanding of the fact that there has been undercounting, that this has implications for society and for public policy. For example, the example I think that you raised of if you want to compensate a family for a COVID death, for the loss of a breadwinner from COVID, unless that person can prove that they died for COVID, you get nowhere. That's why this huge gap, if you have a gap of 10 or something between recorded deaths and actual deaths, you're missing lots of people who need that, who would, for which that bit of money is very important, because they lost someone who would have contributed to that family for the next 30 or 40 years. So I think a prerequisite would be to some sort of acknowledgement of that. And then I think, hopefully we will get to a stage where we will see what we can put in place. But the general problem of transparency of data, availability of data is something that suffuses a whole lot of this, exactly as Malini pointed out as well. Right. Sorry, Dr. Sundaram, please go ahead.
Yeah, please.
Just to draw attention, one very interesting piece of data is look at the total number of expected cases based upon zero prevalence in the district or in the state. For Tamil Nadu, we have seen district data and compare it with the number of reported cases officially. And you can see in Kerala, the gap is minimal. There's almost no gap. Whereas in Tamil Nadu, for example, which I know very well, in Chennai, the gap is 1:9. That's out of 9 cases that you expect from zero prevalence, 1 is reported. Whereas in the Perambalur district, it is 1:149. And in Ramanathapuram district, it is 1:88. And in Kadalur district and most of the districts is about 1:30. So this gap also shows a whole range of both a complex of behaviors and access, and a very robust indicator to actually improve the public health system's ability to capture, to contact, trace, to test. And but it's a complex of many things, demand side and supply side together. And also the nature of administration and governance is rather opportunistically placed on it. So when they see some place reporting low, they just let it be. I mean, that's the way it's played within the system. It's that they don't which seems sort of address itself. So that requires a certain degree of doing. And you did hear a lot of justification of it, saying it's enough if we manage the sick cases. What does it matter that you test everybody, find out the actual number? You can let them be in their houses. So there was a legitimation of this practice that also took place. It was difficult to actually deal with that argument at the ground level, but it's a whole complex.
Yeah.
This is the so in terms of healthy behavior is also there. Even in normal times, morbidity rates are much higher than anywhere else in the country. And therefore, the people who sought healthcare because they had symptoms and they got tested for it is also much higher. And therefore, you have a whole set of things that work together, which we need to understand.
Right. Thank you very much. I think we had a very nice session, very illuminating. Lots of new things I learned today. To quickly sum up what it appears is we started with the question how prepared we are and whether we'll be facing a third wave. I think Dr. Laharia actually really summed it up right at the beginning. I just want to recall, he says that it could be in specific pockets, it could be even state specific. There may not be a nationwide kind of a wave, but it's still possible. The other thing he's pointed out is possibly a new variant could also emerge. We don't know. It depends on what kind of immune escape variants actually come up, or whether it come up at all or not, we don't know. There was an interesting point which Professor Menon said, that actually it's a counterintuitive that Delta is actually kind of, since it's the most dominant, maybe a boon in disguise, that we would now see variants which are actually much more less in strength. I think Sridhar made a very important point that the sledgehammer approach is not what is going to work. The vaccination policy needs to be much more nuanced. And then Malini made a long list of unfinished business. I think it's very important to look at it, because that's a real lesson we've done from that. And Dr. Sundararaman really threw light on what is a very important point in the whole vaccine, is between people who possibly would be left out of all of this. It's important to think about them while framing policies, while public policy experts, while framing those policies, need to keep them in mind. I think that's what he's reiterating through his various examples. Thank you, everyone. Thank you for participating. I thank each one of us. Before I conclude, I want to say again, before I sign off, I would like to remind all the viewers once again that please log on to www.thefederal.com and subscribe the 8th column. Thank you very much.